Hey there, we are here to discuss whether among pediatric patients with acute pain is virtual reality distraction adjunct to analgesic medications compared to analgesic medications decrease pain. Here at the bottom we have the article that we used for this research appraisal in APA citation format. Why did our group select this issue? Our group selected this issue due to the clinical importance of pediatric pain management. Inadequate pain management has been known to cause physiologic, even psychological, deterioration of pediatric patients and in turn perpetuates the child's condition, essentially prolonging care. What is the purpose of this study? Well, between 50% and 80% of the general population experience neck pain at some point in their lives, and every person who experiences neck pain is likely to experience again 1 to 5 years later. The purpose of this study is to compare the effects of virtual reality versus the exercise treatment on pain intensity, conditioned pain modulation, temporal summation, and functional and somatosensory outcomes in patients with non-specific neck pain. And here we have our PICO that's broken down into our various concepts. For study methods, this was a single-blinded, randomized clinical trial conducted by 2 universities within Madrid in Spain with purposive sampling in order to gather 44 participants, specifically 21 males and 23 females, each diagnosed with nonspecific chronic neck pain, ages 18 to 65. The study variables. The independent variables included virtual reality and neck exercises. Dependent variables included changes in cervical range of movement, pain perception, neck pain and disability perception, as well as changes in levels of catastrophism, kinesiophobia, fear avoidance behaviors, hyperanalgesia to pressure and maximum pressure tolerance, endogenous pain inhibition mechanisms, and anxiety related to pain. How were the independent variables operationalized? Well, the first level, the full dive virtual reality, is the first degree of difficulty for the participants, where only tilting movements of the neck are necessary. Once the patient felt comfortable with the system and adapted to the headset, then after a 1-minute rest, the difficulty was increased to the second level. The second degree of difficulty within the game was the virtual reality Ocean Aquarium 3D, where flexion, extension, rotation movements must be integrated alongside sensory element of the surrounding sea. Patients who were allocated to the neck exercises group did 3 series of 10 repetitions for each exercise with a 30-second rest between, while the researchers provided necessary verbal corrections using the same commands for the proper execution of these exercises. The exercise consisted of flexion movements with a ball, picture A, controlled neck extension, picture B, and rotation and tilt exercises, picture C and D. How was each of the dependent variables operationalized? Each outcome was measured pre-intervention, 2 weeks after and 1 month after, and concluded at 3 months after. To save time, I'm going to list the dependent variable and its associated tests. Cervical range of motion was measured with the goniometer by the physiotherapist. Pain perception was self-reported visual analog, 0 being no pain, 10 being the worst. Neck pain and disability perception was measured by the Neck Disability Index scale that must be answered with a numeric value, 0, no disability, and 5, complete disability, with a maximum score of 50 points, with higher scores indicating greater neck disability. Catastrophism was measured by a 13-item pain catastrophic scale, maxing out at 52, higher indicating a worse score. Kinesiophobia was measured by an 11-item Tampa scale for kinesiophobia. The final score can range between 11 and 44 points, higher being worse. Fear avoidance behaviors were measured by the Fear Avoidance Beliefs Questionnaire, the higher score being worse. Levels of hyperanalgesia to pressure and maximum pressure tolerance were measured by the pressure pain thresholds using an algometer on the first finger, trapezius muscle, and patient's tibia. Endogenous pain inhibition mechanisms measured by conditioned pain modulation and temporal summation used the algometer in an occlusion band. Anxiety related to pain was measured by a 20-item pain anxiety symptom scale scoring from 0 to 100, with higher scores indicating greater pain-related anxiety, and researchers strategically used these internationally recognized assessment tools and provided the evidence-based practice within references to prove the reliability and validity of these various assessment tools that they used. For ethics, this again was a randomized single-blind control trial and was conducted in conformity with the Consolidated Standards of Reporting Trials, aka CONSORT requirements. This study was also approved by the Ethics Committee of the Rey Juan Carlos University. and met all of the requirements that they laid out. The study was also registered within the United States Randomized Trials Registry on clinicaltrial.gov with the following NCT number. Participants also received individual explanations of the study and each procedure, and written and informed consent was obtained by each participant. For data analysis, the descriptive statistics used to describe the studies included the mean, standard deviation, and route for parametric variables, whereas non-parametric variables were median or mode, ranges, and quartiles. The descriptive statistics used to summarize data in the study included the mean, standard deviations, medians, and interquartiles for the continuous data. The Shapiro-Wilk test assisted in fitting the variables into a normal distribution, while the simple analysis variance or mixed variance models 2x4 with a post hoc Boniferroni test were applied for multiple comparisons. The study ensured to keep a 95% confidence interval and made sure that all values that were under 0.05, the p-values under 0.05, were statistically significant. So, while the magnitude of the effect was classified as small, 0.2 to 0.49, medium, 0.5 to 0.79, or large, 0.8, as defined as Conehead's method. For the findings, reduced pain-related kinesiophobia was the most statistically significant, whereas the other ones kind of fell in between. And we kind of discussed this more with limitations and strengths. So the limitations, there was no placebo group, so we couldn't compare the non-specific effects of this therapy. Similarly, there was no group that received passive treatment, meaning both of our groups underwent active interventions, which may explain the minimal differences between groups. The patients could not be blinded since they were aware of wearing immersive virtual reality devices, and the results only showed the effects of the therapy within a short term, over those 3 months. The strengths, however, included that the obtained results showed that virtual reality could be an effective tool for reducing the pain-related fear of movement, and is an effective exercise in decreasing pain intensity or modulating pain and as effective as exercise was. It provides several benefits by enhancing adherence to treatment and autonomy to practice at home. For the appraisal, the article did not fully answer our question since the patient population was adult chronic pain rather than acute pediatric pain, and the comparison was exercise rather than analgesic medications. It does, however, experimentally address the virtual reality and its possible role in clinical pain reduction. Although not conducted within the United States, the study was registered at clinicaltrials.gov, and despite the geographical location, the study and intervention could easily be applied within U.S. clinical settings, since the device and patient population is not limited by Spain's health system structure and can easily be duplicated to address American patient populations, even expanded to address various patient diagnoses. For application, the research article again did not answer our group's clinical question. The study's main objective was instead to compare the effects of virtual reality versus exercise on pain intensity rather than virtual reality and analgesia versus analgesia alone. A study that would answer our question would need to include a sample of pediatric populations. The independent variable should include treatments of just analgesia, virtual reality and analgesia, and virtual reality alone. The dependent variable may remain the same to measure the reduction in pain in the subject. The setting of a children's hospital or clinic within the United States would be more feasible to conduct a study to obtain a sample of the pediatric population. The study also took place in Spain, and pain may be perceived differently in different cultures and different regions, which is something important to consider. So here's our credit slide, and this is super important because everybody participated and everybody included amazing information and material, oh my goodness, for this entire thing. And I hope you guys enjoyed it, and thank you so much.